As part of the body's adaptive immune response, lymphocytes are imprinted for migration to areas of inflammation in specific tissues. Entyvio targets a discrete subset of imprinted T cells that preferentially migrate to the GI tract. The accumulation of such immune cells within this tissue contributes to inflammation that is characteristic of ulcerative colitis and Crohn's disease. As part of a process called lymphocyte trafficking, a small number of T cells are known to express the alpha-4 beta-7 integrin, which binds to the mucosal addressin cell adhesion molecule 1, or MAdCAM1. The binding of alpha-4 beta-7 to MAdCAM1 causes cells to enter the inflamed tissue from the vasculature. This interaction primarily occurs at the vascular endothelium in the lamina propria intestinal submucosa and gut-associated lymphoid tissue, the main sites of MAdCAM1 expression. Entyvio works by binding to the alpha-4 beta-7 integrin, preventing its interaction with its ligand, MAdCAM1. It selectively inhibits the adhesion of T cells to the endothelial surface of blood vessels within the gastrointestinal tract. As a result, Entyvio selectively restricts T cell recruitment from the vasculature into the tissue, reducing inflammation within the gastrointestinal tract associated with ulcerative colitis and Crohn's disease.
Endoskopi ultrasonografi atau EUS adalah tindakan minimal invasif dengan menggunakan alat endoskopi yang dikombinasikan dengan pemeriksaan ultrasonografi. Dengan tindakan ini, kita bisa melihat lebih detail mengenai organ-organ di sekitar abdomen, di sekitar perut, seperti hati, pankreas, kelenjar getah bening, dan dinding saluran cerna lebih detail. Tindakan ini juga bisa dilakukan dengan menggunakan biopsi jarum halus, sehingga dokter bisa mendapatkan sampel cairan atau sampel biopsi atau mengeluarkan cairan dari dinding perut secara minimal invasif. Tindakan ini merupakan salah satu alternatif yang non-invasif dibandingkan tindakan pembedahan secara langsung. Endoskopi ultrasonografi diindikasikan pada kelainan-kelainan di saluran cerna, seperti misalnya kista di pankreas, atau cairan di pankreas, atau tumor di pankreas, atau kelainan di saluran empedu. Misalnya ada kecurigaan ke arah tumor saluran empedu atau batu saluran empedu yang masih meragukan, maka bisa dilakukan tindakan ini. Indikasi lainnya adalah tumor-tumor di saluran cerna yang membutuhkan pemeriksaan lebih detail, keterlibatan lapisan-lapisan saluran cerna. Juga bisa dilakukan tindakan ini.
Selama prosedur, perangkat ultrasound kecil terhubung dengan endoskopi. Endoskopi adalah tabung kecil bercahaya fleksibel dengan kamera terpasang. Dengan memasukkan endoskopi dan kamera ke saluran pencernaan bagian atas atau bawah, dokter dapat memperoleh gambar ultrasonografi organ yang berkualitas tinggi. Karena EUS dapat mendekati organ yang diperiksa, gambar yang diperoleh dengan EUS seringkali lebih akurat dan detail daripada gambar yang diberikan oleh USG tradisional yang harus dilakukan dari luar tubuh. Kapan EUS dilakukan? Pertama, untuk evaluasi stadium kanker. Lalu, untuk evaluasi pankreatitis kronis atau gangguan pankreas lainnya. Kemudian, untuk mempelajari kelainan atau tumor pada organ, termasuk kantong empedu dan hati. Kemudian, untuk mempelajari otot-otot rektum bawah dan saluran anus untuk menentukan alasan terjadinya kebocoran usus yang tidak disengaja atau inkontinensia. Dan yang terakhir, untuk mempelajari nodul atau benjolan di dinding usus.
Endoskopi ultrasonografi sudah dapat dilakukan di Pusat Endoskopi Saluran Cerna Rumah Sakit Pusat Cipto Mangunkusumo. Alat ini memang masih jarang didapatkan, memang hanya pada center-center besar seperti di RSCM.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, dear professors, doctors, and colleagues. Welcome again to Virtual Jakarta International GI Endoscopy Symposium. We are very happy to welcome you again today to our virtual congress. So continuing the previous stage, for right now, we will have one plenary lecture, one panel discussion and meet the expert, and one symposium. For the first agenda is plenary lecture 5 with the topic recent management of upper non-variceal GI bleeding, sponsored by Takeda. For this plenary, it will be moderated by Dr. Hasan Maulahela from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo National General Hospital. So to Dr. Hasan Maulahela, you may please lead this session. Thank you.
Thank you, Dr. Saskia. Assalamualaikum warahmatullahi wabarakatuh. Very good morning to all colleagues and all participants. We are glad today we can still join again in Jakarta International GI Endoscopy Virtual Symposium. Now it's time for our plenary lecture, by the topic of recent management of upper non-variceal bleeding. Before we begin, I will introduce our speaker, Professor Marcelo C. Madibrata, PhD, Fellow of American College of Gastroenterology, Fellow of American Society of Gastrointestinal Endoscopy. He is a professor of medicine in Division of Gastroenterology, Department of Internal Medicine, University of Indonesia. He is a well-renowned gastroenterologist in Indonesia also and in Asia Pacific. He has published many numerous research and literature both nationally and internationally. Without further ado, I will please Professor Marcelo Simadibrata. The time is yours.
Thank you, Dr. Hassan. Thank you, Dr. Hassan Malahela. As the moderator at this plenary session in GGS, good morning, everyone. I have duty to present my lecture about recent management of upper non-variceal GI bleeding. As you know, that we have a lot of patients coming to the hospital with upper GI bleeding, and recently the frequent cause is non-variceal causes. Yeah, so I will share the screen. Yeah, this is my outline, and this is the introduction that we have a lot of patients with non-variceal upper GI bleeding, and the frequent cause is non-variceal GI bleeding is erosive gastritis, and the second peptic ulcer. And sometimes the management of upper GI non-variceal GI bleeding is difficult. So we need comprehensive therapy, collaboration between internist, surgeon, radio interventionist, and other doctors, medical doctors. And this is data, but it's already old, 2001 until 2005. And this from this period, the frequent is rupture of esophageal varices. But after maybe recently in the 5 years period in 2015, the frequent is erosive gastritis, and second the peptic ulcer, and the esophageal varices is now number 2 or number 3. Yeah. And this is the risk factor of non-partial esophageal, non-esophageal upper GI bleeding, and the cause is usually caused by the NSAID. This is the most common, and then second we have the Helicobacter pylori infection. This is the data in 2012, but now since 2015 the frequent is NSAID, the cause, the frequent cause. And one of the management of the patient with upper GI bleeding is stratification of the patients. We use the Roccal score or blood spot score, and also we use the endoscopy examination to stratify the high risk or the low risk of the upper GI bleeding. And this is Roccal scoring score. So, we use the clinical factors to stratify these high risk or low risk patients. If the patient has a high score, maybe the age and or the pulse rate and the systolic blood is low, so the patient has high risk of score, so the patient must be admitted in the ICU or high care unit, because it is very dangerous to patient for the regular admission. And this is the other one, is the blood spot scoring system. We can use the clinical parameter and like level of ureum, level of hemoglobin, rapid pulse, and is there melena or not? Yeah. So if the patient has high score, the patient must be admitted in the ICU. Another factors, we use the other the risk factors in the patient, like age more than 60 years, and bleeding onset in the hospital, comorbid, and the other fresh blood in the nasogastric tube, coagulopathy. If the patient has a high score, so maybe the patient must be admitted in the ICU or high care unit. This is one of the endoscopic stratification. If the patient has the A is visible vessel and also bleeding, fresh bleeding, so the patient must be admitted in the high care unit or intensive care unit. If the patient has just white base clean ulcer, so the patient can be admitted in the regular room. This is the pathophysiology of the bleeding, upper non-variceal GI bleeding, is the imbalance between aggressive factors and defensive factors. We have the patient underlying diseases like shock, cardiovascular disease, or liver or renal failure, one of the underlying diseases of the upper GI bleeding. And this is the imbalance if the gastric acid or the pepsin NSAID is more higher than the mucose bicarbonate, so the patient will get upper GI bleeding. Yeah. This is the diagnosis of upper GI bleeding. It's made by anamnesis, historical examination, physical examination, and laboratory findings, and including endoscopy examination. And for the medical history, we have to ask how much the patient vomit blood, hematemesis, or having a black stool, and is the patient has recently consumed NSAID, antiplatelet, or is there a patient has underlying disease like liver disease, diabetes, or cardiovascular disease, and or kidney disease. Yeah, we have to ask to the patient, and we have to check the physical examination. How is the blood pressure and the pulse? Is there an increase of pulse or not? Is there any shock or not? Or is there absence or liver cirrhosis sign? And is there any anuria or oliguria of the patient? We have to check the patient physical examination. And then we do the supporting examination, like we insert the nasogastric tube and we see is there any fresh blood or not. And also we check the hemoglobin every 6 to 8 hours. If there is a decrease, we have to give transfusion. And also we can check the clinical, the other examination, clinical examination of patient. This is the endoscopy examination. If there is spurting fresh blood, we call it forest 1. And if the lesion without bleeding, we call it type 3. So in the type 1, we have to admit the patient in the ICU or high care unit. But if the patient has the type 3 lesion without bleeding, so the patient can be admitted in the regular room. And this is the picture. This number 2, there is a fresh blood. Yeah. Number 1, the fresh blood spurting. And then number 3, there is a visible vessel but clean base. Yeah. But if the patient has the clean base and no bleeding, we can admit the patient at the regular room. This is the complication of upper GI bleeding, like shock hypovolemic, acute renal failure, multi-organ failure, and if there is no treatment, the patient will get will be dying. Okay, this is the management of patient. So we divide the management into the early management and advanced management. The remanagement consists of early evaluation, like the stratification, like that, and then we give resuscitation, fluid resuscitation. And the early management of upper partial GI bleeding divide on multidisciplinary approach. We have there is a collaboration between general physician and then surgeon and also the interventionist, and then we have to stratification. We insert the nasogastric tube, and then we give the proton pump inhibitor in this patient, like continuous infusion proton inhibitors. And if the patient has active bleeding, we do the endoscopic therapy, but only if the patient from endoscopy we have adherent clot, we consider endoscopic therapy. If there is from endoscopy we have the flat spot or clean base, no endoscopic therapy, just give the oral PPI. But if you have after the endoscopic therapy, before and after, you can give the intravenous PPI, bolus or infusion. And if there are adherent clot, we have to give intravenous PPI, bolus plus infusion. Yeah, this is the algorithm from the consensus of Indonesia, upper GI bleeding. So if there is the score is high, so we have to give the endoscopic therapy. Like there is adherent clot, we have to give endoscopic therapy. But if there is a clean base, there is no bleeding, we can check the Helicobacter pylori, and then we give eradication therapy, and the patient can go back, can go home as soon as possible. This is algorithm from Triadapa Philophilus. He said that if the patient has upper GI bleeding, we have to do, we give the intravenous PPI infusion first, and then if there is a high risk, we can do the endoscopy. If there is high risk stigmata, we do the endoscopic therapy, but low risk stigmata, we just give oral PPI therapy. This is also another algorithm by Foti, yeah. So if there is a peptic ulcer but active or high risk bleeding, we do the endoscopic therapy. But if low risk, just monitor and the bleeding stop, we give oral therapy. And this is also the Albarkun in 2010. He's mentioned that the first is early risk stratification. We do endoscopy therapy in 24 hours. And then if the patient will be given PPI therapy. And for the high risk patient, we do the endoscopic therapy. Yeah. This is the endoscopic therapy that is can be given for the patient, like thermal injection by adrenaline, or we can give mechanical like hemoclips, band ligation, yeah. Or we do the combination therapy. Usually, the combination of the BGO, the World Organization, we do the combination therapy, injection, adrenaline plus thermal therapy, or injection plus mechanical therapy. This is the same, but for if the patient already no bleeding, so we can do the if the patient has bleeding, we have general supportive exam management, and we give pharmacologic therapy like PPI, and special we do the endoscopic therapy or we do the surgery therapy, and also the treatment of active peptic ulcer. And usually we can give PPI better than H2 receptor. But if you don't have the PPI, we can give the H2 receptor antagonist. And we can add drug to increase the defensive factor like Straxid, Sucralfate, Ribamycin, and Tefrenon. And to clean the blood clot, usually before we do the endoscopy, we can give prokinetic like metoclopramide or other prokinetic. Yeah. And this is the proton pump inhibitor for GI bleeding. We can give bolus 60 milligram for lansoprazole, and then after that we give the continuous therapy 6 milligram per minute, yeah, until the bleeding stop, and then we switch to oral PPI therapy. We can use the PPI omeprazole, lansoprazole, pantoprazole, or esomeprazole. Yeah. The reason we give PPI for upper GI bleeding because the PPI increased the pH for above 6, and then there will be stabilization of the blood clot on pH above 6. Yeah. And this is meta-analysis by Kuro, said that if the patient were given PPI therapy, so the bleeding will be stopped, and then we decrease the need for surgery, and we decrease also the death by ulcer, yeah, and but there is no improvement with the non-ulcer death. But for this, there is a lot of benefit if we use PPI for the upper GI non-variceal bleeding. And this is one of endoscopic therapy. It's the hemoclips. There is a visible vessel, and then we put the hemoclips and then stop the bleeding. And we have also another modalities like argon plasma, or maybe um, some medication to stop to coagulate the bleeding, and then we have a lot of laser and other modalities to do this hemostatic endoscopic therapy. Yeah, this is if the patient has Helicobacter pylori, we have to eradication the Helicobacter pylori with PPI plus 2 antibiotics. And as you know that if the patient has dual antiplatelet therapy, it's a high risk for upper GI bleeding. So we have to use PPI to reduce the adverse events of the clopidogrel and aspirin, the dual antiplatelet therapy. For prevention and for the treatment, also we can use the PPI infusion therapy to treat the bleeding caused by this antiplatelet agents. This is the aspirin and treatment has a high risk for the bleeding, but if we give the PPI, we can prevent the bleeding. So PPI can prevent the bleeding caused by Helicobacter pylori, or by NSAID, or by the antiplatelet therapy. This significant significant result of the PPI prevention if we give the patient with Helicobacter and also the NSAID. Why we give the PPI for upper GI bleeding? Because if the pH is above 6, so there the aggregation will can be stopped. Yeah, if the pH the pH 6, this aggregation is 76%. If the pH 6.4, the disaggregation will be 60%. And if the pH above 7.3, this aggregation 0%. So the bleeding will be stopped. This is the US FDA label changes that lansoprazole has no interference with the use of clopidogrel, and it is very safe if the patient gave the lansoprazole and also clopidogrel. But we cannot use the omeprazole until now because there is a side effect for the metabolism in the liver. So this is also the same if we give PPI, if the pH the pH can be can be after 6, so there will be reduction of rebleeding after endoscopic intervention. So this is a study about the intravenous infusion of PPI. So the pH of the stomach will be above 6, and then the patient, the bleeding will be stopped. This is also a study that high-dose PPI is effective in reducing the rebleeding and the need for surgery, because the pH is high, and then we can stop the bleeding, and the patient will get benefit for the infusion of PPI therapy. This is a study by Variceal and others showed that the lansoprazole infusion can increase the pH and then can increase the improvement of the patient and can stop the bleeding. Yeah, this is a study by Ari Farsham and Arini Setiawati said that the improvement of the uh, patient will get benefit on the day 4 and the day 5. Yeah. And also we have a lot of PPI like pantoprazole, yeah, and also rabeprazole, yeah, and there is no interaction between lansoprazole, pantoprazole, and other medication. There is benefit if you use the pantoprazole, yeah. So in conclusion, that the diagnosis of upper non-facial GI bleeding based on anamnesis, medical history, physical examination, supporting examination, including endoscopy examination, and the management of upper GI bleeding include non-pharmacologic, endoscopic therapy, or if failed, we can do the surgical therapy or radiologic intervention therapy. So the diagnosis and management of GI bleeding can use the Indonesian consensus or other guideline for optimal result. And the optimum result of GI bleeding management based on facilities, physician competency, and cooperation between internist, gastroenterologist, and surgeon and radiology interventionist. Thank you very much for your attention. So this is my talk, and then I give the time to the moderator. Thank you, Dr. Hasan.
Yes. Thank you very much, Prof. Marcel, for a comprehensive lecture. Because this is a plenary lecture, I think we don't have a Q&A session. So this is the end of our plenary lecture and a very interesting and comprehensive lecture from Prof. Marcelus Simadibrata. So I will send back to MC Dr. Saskia to resume the conference.
Thank you very much, Dr. Hasan and Prof. Marcel Simadibrata for the very insightful plenary lecture. To Prof. Marcel and Dr. Hasan, we will have a photo shoot. So you please look at the camera. Okay, I will count in 1, 2, 3. Once more, 1, 2, 3. Okay, thank you very much. And also, we would like to say thank you to Takeda, our sponsor. And now, please take a look at the coming video by our sponsor, Takeda. Okay, thank you very much. Ladies and gentlemen, the second agenda is panel discussion and meet the expert with the topic Diagnostic and Therapeutic Modalities in GERD, sponsored by ASI. For this panel discussion, it will be moderated by Dr. Darmika Joyoningrat from Division of Gastroenterology, Department of Internal Medicine, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo National General Hospital. So without further ado, I would like to invite Dr. Darmika to lead this session. Thank you.
Thank you, Mr. Chairman. Good morning, ladies and gentlemen. Good morning, Professor Ronnie Fass. Good morning, dear Amanda. So we have the second session with topic diagnostic and therapeutic modality in GERD. We have two speakers. We have hello? Hello?
Yes,
Are you
we can
here?
hear you. Yes,
My
we can
voice?
hear you, Dr. Darmika. Yes.
Okay. Yes. So we have two speakers. First, Prof. Ronnie Fass. She is an expert in neurogastroenterology and motility disorder from USA. And the second speaker is Dr. Amanda from Division Gastroenterology, University of Indonesia. So first, we invite Prof. Ronnie Fass as first speaker. Please, Prof. Ronnie.
Thank you very much. Let me just share my slides. Okay. So first of all, good morning, everybody. It's a great pleasure for me to be here, and it's a great honor. And thank you very much for the opportunity to give you a lecture on the topic, the role of esophageal manometry and reflux testing. So my presentation is not going to be too long. I'll try to be really focused in giving you kind of the overall and current expectation in relation to pH, or I would call it more reflux testing and manometry. So first of all, one of the recent publications that discuss modern diagnosis of gastroesophageal reflux disease is the Lyon Consensus Meeting. The Lyon Consensus Meeting, as you could see, this was published about 2 years ago, tried to identify the proper testing that is needed in order to make the diagnosis of gastroesophageal reflux disease. Now, because the focus of my presentation is on pH or pH impedance and manometry, then I'd like you to focus on the right side of this slide. So if you look, it says conclusive evidence for pathologic reflux. In the case of pH or pH impedance, it's the presence of acid exposure that is greater than 6%. In the case of borderline or inconclusive evidence, then the acid exposure time should be between 4 and 6%, and reflux episode between 40 and 80. Prior to the consensus meeting, acid exposure time that was greater than 4% was acceptable. With the introduction of the consensus meeting, it was decided that between 4 and 6%, it would be considered to be borderline, and in relation to acid exposure time that is greater than 6% would be conclusive. I'm not sure here, but there is a lot of disturbances. Do you hear also these disturbances as I do? No? Okay. So I will continue. In relation to what's considered to be adjunctive or supportive evidence of gastroesophageal reflux disease is the use of reflux symptom association, which we currently use symptom index or symptom association probability. And if you have reflux episodes more than 80, and this is the number of reflux episodes that the patient experienced during a 24-hour test, either impedance or regular pH test, and regardless of the characteristics of the reflux episodes. They could be acidic or non-acidic. In addition, the presence of low MNBI and low PSPWI is adjunctive and supportive evidence. I will talk about these two novel metrics in the next few slides. If the patient has acid exposure time that is less than 4% or reflux episodes that are less than 40, this is evidence that against pathologic reflux. From esophageal manometry point of view, the presence of hypotensive esophagogastric junction or hypotensive lower esophageal sphincters, the presence of hiatal hernia, or the presence of esophageal hypomotility, either ineffective esophageal motility or absent contractility, they're all adjunctive or supportive evidence. They do not provide conclusive evidence of pathologic reflux. In relation to the novel metrics that are available in order to make the diagnosis of gastroesophageal reflux disease, they've been introduced in the last decades, and they are extracted for impedance plus pH study. Now you have to calculate them because they're not provided by the software of impedance plus pH in order to calculate them. The first one is called the PSPW, or the post reflux swallow-induced peristaltic wave, and PSPWI is the index. So what is the post-reflux swallow-induced peristaltic wave? And what is the index? And how does it help us to diagnose gastroesophageal reflux disease? Well, in healthy subjects, usually reflux episodes trigger primary peristalsis. So the subject experience reflux episodes, and within 30 seconds, usually the subject initiate primary peristalsis. And the purpose of it is to neutralize acidified esophageal mucosa with saliva. And so this is what is called a PSPW, okay, which is the post-reflux swallow-induced peristalsis. The PSPW index is the proportion of reflux episodes that are seen on pH impedance monitoring that are followed by a PSPW. Okay, now the index reflects the integrity of primary peristalsis stimulated by reflux episodes, and that's been shown to correlate with the contractile reserve of the esophagus as it is assessed when you use multiple rapid swallows. The MRS, which has 5 rapid water swallows, allows us to assess contractile reserve of the esophagus during high resolution esophageal manometry. And so if you have a normal PSPW index, that's usually associated with a normal contractile reserve or the presence of it. If you have an abnormal one, then it's usually correlate with the likelihood that it's either weak or absent. Now, why the PSPW index? Because it's an excellent parameter in differentiating erosive esophagitis and non-erosive reflux disease from functional heartburn or healthy control. And the sensitivity and specificity are very high, as you can see. The sensitivity is between 99 to 100%, and the specificity is about 90%, 92%. So it's a very attractive parameter to use. The only thing is, as I said, it is not provided by the computer, and that means that you have to manually calculate it, which is a very time-consuming process. Here is an example of how PSPW looks like. If you look at the left side, you can see evidence of reflux coming from the distal esophagus to the proximal. And if you look at the pH, this is a reflux that does not cross the number 4, so it's a weakly acidic reflux. And then on the right side, you can see that immediately after the reflux reached the proximal part of the esophagus, within 30 seconds, there is again a decrease in the impedance. It goes all the way from the proximal esophagus to the distal esophagus, which is suggestive of a swallow. And that swallow is the PSPW. And as I said, you have to go through the whole strip of the pH impedance and then look at every reflux event and see if it is associated with PSPW. And then you calculate how many of these reflux events are associated with PSPW. Obviously, it's time consuming, but more than that, it is highly associated with a very high inter-rater variability. Here's another example, but this time with an acidic reflux. You can see that the patient experienced a reflux event. It's the yellow part on this strip, and it goes from the distal part to the proximal part of the esophagus. And because this time the pH drops below 4, then this is an acidic reflux. And then within 30 seconds after that reflux reached the upper part of the esophagus, you can see a decrease in impedance that starts from the proximal part all the way to the distal part. It's the red arrow, and that's the PSPW. And so the index is calculating and see how many of these reflux events are associated with a PSPW. And there is evidence that the PSPW index is the lowest in patients with untreated erosive reflux disease. And then if you look, the PSPW increases in patients with erosive reflux disease that are treated. Then it's a little bit higher in patients with untreated non-erosive reflux disease, the same in patients with treated non-erosive reflux disease. And the highest, as you could see, in control patient subjects and normal subjects, or patients with functional heartburn. So it's suggestive that the PSPW index, if it's high, it's more suggestive of normal control or functional heartburn. If it's low, it's more suggestive of gastroesophageal reflux disease. The next one that we're going to talk about is the MNBI, which is the mean nocturnal baseline impedance. Again, this is another novel parameter that is not provided by the computer. So you're not going to get it from the automatic analysis that the impedance pH computer provides us. Instead, you have to do the calculation yourself. And what is MNBI? It's the average of baseline impedance at each channel over 10-minute periods around 1, 2, and 3 a.m. from pH impedance tracings. The idea is that you need to catch a period of time in the esophagus of the patient where there is very little peristalsis going on, and usually sleep time is a great time for that because saliva production goes almost to zero, and swallowing, which generate primary peristalsis, is almost completely abolished. And so this is really a great time where you can measure the baseline impedance of the esophageal tissue. There is a correlation between mucosal integrity and baseline impedance. So increase in mucosal integrity results in lower impedance, and increase in mucosal integrity results in increase in impedance, and decrease in mucosal integrity results in decrease in impedance. They correlate with each other. So it's an indirect parameter that tell us about mucosal integrity. And so it can give us an information, for example, because we do know that patients with erosive esophagitis, when you do impedance assessment in a quiet time of the esophageal tissue, the impedance will be low, and it's because of the inflammation of the mucosa from the erosive esophagitis, which decreases mucosal integrity. The same thing is with Barrett's esophagus. It's a little bit higher if you have patients with non-erosive reflux, although they do have some level of inflammation, but it's not as high as in patients with erosive esophagitis. And obviously, in normal control, where there is normal mucosa, then the mucosal impedance increases because there is increase in mucosal integrity. So it's a very simple way that you can calculate and find out, just based on the numbers that you get, does the patient have GERD or they don't have GERD? Now, this is a figure from a paper where they incorporated these two novel metrics, the PSPW index and the MNBI, to show you how it can be used based on numbers and percentages in order to make a diagnosis. So a very low MNBI and a very low PSPW index is associated with refractory GERD. Then you have erosive reflux disease, healed erosive esophagitis, non-erosive reflux disease, and hypersensitive esophagus. So in normal subjects and functional heartburn, in MNBI are going to be higher than 2,292 ohms and above 61% PSPW index. So you can use those numbers in order to make a diagnosis if the patient does have GERD or does not have GERD. Another tool to assess if the patient has GERD or no GERD, which could be normal controls or patients with functional esophageal disorder like functional heartburn, is the mucosal impedance. So unlike using the pH impedance, where we look specifically at certain time during sleep time, 1 o'clock in the morning, 2 o'clock in the morning, 3 o'clock in the morning, this is a simple test. So when you have the patient in the endoscopy room, after you sedate them, you actually put the scope in, and through the channel, the biopsy channel, you can pass a probe. And that's a mucosal impedance probe. It has at the tip of it two impedance channels that can measure impedance. And then you can get a spot measurement of the mucosal impedance. Spot measurement, just you touch the esophagus and then you get an immediate measurement, and that can give you an idea based on normal range or range that is associated with gastroesophageal reflux disease, with erosive esophagitis, non-erosive reflux disease. You can determine on the spot within 6 seconds if the patient has GERD or doesn't have GERD. Again, this is the mucosal impedance. It is not FDA approved at this point, but it is available in a few centers in the country. We have it, and we've been using it for research primarily, but we use it also in our patients. However, this is actually what you see here, the probe with a 2 sensor at the tip is considered to be an early prototype. There were some issues to try just to get mucosal impedance measurement from 2 sensors. And so as a result, there is now a different mucosal impedance probe. And this time it is actually a balloon, and along the balloon, there are 2 rows of 10 impedance sensors on each one. And so what you do is this type of balloon with impedance sensor on it is not passable through the channel, just too big. So what you do it is you pass it along the endoscope. You make sure you position it in the lower part of the esophagus, where the tip of it should be above the esophagogastric junction. And then you pull the scope and you inflate it, and you inflate it 6 times, and each time you get a measurement. And based on these measurements, again, the computer actually can tell you that the patient has a high likelihood of having gastroesophageal reflux disease, or maybe they have a functional esophageal disorder, or they're normal and they don't have GERD at all. So it really helps us to separate between patients with GERD and those that don't have GERD, and in a very quick manner. So here is the mucosal impedance data, and you can see on the right side that you do measurement, and this was actually with the early prototype where they put just the probe, and they did measurement at 2 centimeter, 5 centimeter, and 10 centimeter. Today, with the balloon and the row of 10 sensors, there's no need really to move the balloon into different locations, because the balloon itself covers these 2 centimeter, 5 centimeter, and 10 centimeter locations. But you can see that at the bottom, the purple line, it's eosinophilic esophagitis. Above it is E+, which is erosive, that means endoscopy positive. So these are erosive esophagitis patients. Above it, endoscopy negative or pH positive, that's non-erosive reflux disease. And above it, E negative, pH negative. These are in symptomatic subjects. This would be a functional esophageal disorder. In non-symptomatic, that would be normal controls. And above it, that's what you see in patient with achalasia. So if the numbers fall along any of these lines, then one can guess what does the patient have by doing spot measurement when the patient gets their endoscopy, and it adds about 1 minute to the endoscopic procedure. This is another tool that we have. It's the combination of impedance plus pH and actigraphy. You can see on the left side, there is a watch-like device. And that watch-like device is an actigraph. And what the actigraph does, it tells us if the patient is asleep or awake based on hand movement. Inside the watch, there are oscillometers, and they follow hand movements. And if you have a lot of hand movements, that means you're awake. And if you have very few of them, that means you're asleep. Based on that, we can determine, without the need of patients documenting, but we really can determine whenever the patient fell asleep and when they woke up, so we can get accurate calculation of impedance changes, pH changes during sleep time and during awake time. In fact, it's so sensitive that it can even tell us when the patient was in bed and awake, and when they woke up during the night because they had reflux, for example, or when the patient woke up in the morning. So it helps us to do impedance and pH measurements that are exclusive for awake period and sleep period. pH impedance predictors of symptom improvement has been shown to be the presence of abnormal acid exposure time, and then symptom association probability. These were probably the most important ones from patient outcome. Recently, the ACG came up with clinical guidelines of the use of reflux testing in gastroesophageal reflux disease. As you can see, the quality of the evidence was very low, low to very low, and a lot of the recommendations were conditional. But I think it's important to understand those, because this is probably what we're going to see in upcoming publications. These guidelines were published last year, and they're available online. They recommended the use of ambulatory reflux monitoring over patient-reported symptoms on GERD questionnaires. They also recommended the use of ambulatory reflux monitoring over the assessment of response to PPI therapy to make the diagnosis of reflux disease. They also suggest the use of ambulatory reflex monitoring over upper endoscopy alone, especially in patients with an upper endoscopy that does not that is normal, and this is for a conclusive diagnosis of gastroesophageal reflux disease, especially in patients that are not responding to PPI treatment. They also recommend the use of ambulatory reflex monitoring performed off PPI therapy over ambulatory reflex monitoring on PPI therapy to make the diagnosis of gastroesophageal reflux disease in patients with typical symptoms of GERD, but they didn't have any study that showed that they have GERD. They recommend the use of prolonged wireless pH monitoring, so the Bravo wireless pH capsule over a catheter-based. They also suggest the use of ambulatory pH impedance monitoring on PPI therapy over endoscopic evaluation of pH monitoring alone to diagnose persistent GERD in adults with typical esophageal reflux symptoms and previously confirmatory evidence of gastroesophageal reflux disease. And they also suggest for patients with esophageal symptoms being evaluated for anti-reflux surgery, abnormal acid exposure time to be considered a predictor of treatment outcome, reflux symptom association, and mean nocturnal baseline impedance provide adjunctive value. And I think we discussed that. They also made some recommendations about extraesophageal reflux symptoms and atypical symptoms. They recommend ambulatory reflux monitoring, specifically pH impedance monitoring, that is performed off acid suppression over other diagnostic tests to make a diagnosis of extraesophageal reflux. They also suggest upfront ambulatory reflux monitoring of acid suppression over empiric PPI therapy to make diagnosis of extraesophageal reflux symptoms. And they suggest high resolution manometry with postprandial monitoring to confirm the diagnosis of rumination. And if clinically necessary in patient with esophageal symptoms, suspicion for rumination symptoms. And the same thing, they also recommend in patients who are suspected to have supragastric belching, but using pH impedance. So what is the role of pH impedance in 2020? In the case of refractory GERD, it can help us to identify an overlap of GERD with functional heartburn or reflux hypersensitivity. So these are patients that we know that they have gastroesophageal reflux disease. And as a result, pH impedance should be done on PPI. In refractory heartburn, it has no role. Testing should be done off treatment. This is the ACG clinical guidelines for manometry testing in gastroesophageal reflux disease. In essence, it does not really make a diagnosis of gastroesophageal reflux disease, but it can complement it, especially of chest pain that is not responsive to PPI therapy. It's important in ruling out motor disorder for assessing esophageal peristaltic performance in patients with GERD symptoms. And it should be performed before anti-reflux surgery or invasive GERD management. And high-resolution esophageal manometry complement endoscopy and barium esophagography in improving the diagnostic yield of identifying Yale hernia. So this is the ACG clinical guidelines recommendation for esophageal testing in gastroesophageal reflux disease. I would just say here that if you have reflux suspected, in the case of esophageal, they do recommend that you will do PPI trial first. In the case of extraesophageal, they suggest to go immediately to testing, and they suggest reflux monitoring. And this is to determine symptom association. And now what I would like to do is to move on. This is the role of high resolution esophageal manometry in GERD patient. It's primarily to exclude major esophageal motor disorders such as achalasia, distal esophageal spasm, jackhammer esophagus, absent peristalsis, and EGJ outflow obstruction. If you have ineffective esophageal motility or fragment peristalsis, that does not exclude gastroesophageal reflux disease. I would use this kind of a management algorithm. So in order to tell you when to use each one of these tests. So if you have a patient with heartburn and they do not respond to PPI once a day, then they should go through optimization of PPI treatment, which is mentioned here. If they don't respond, then you usually double the PPI dose. If they don't respond, then it's usually recommended to perform an upper endoscopy with biopsies. If those are negative, then if the patient has history of proven gastroesophageal reflux disease, then you should do impedance plus pH on PPI treatment. If the patient does not have a proven history of gastroesophageal reflux disease, then you have to stop the PPI treatment and then perform as it is recommended, preferably in a Bravo wireless pH capsule. And if you don't have it, then just perform the regular pH-based, catheter-based 24-hour pH. If these tests are negative, then you should do an esophageal manometry to assess for a major esophageal motor disorder. If this is negative, then you need to look again at your impedance plus pH or the pH capsule and see if there is an association between symptoms and reflux events, because if there is, then you're looking at reflux hypersensitivity, and if you don't, then you're looking at functional heartburn. And I think if you have that kind of management algorithm, you will know how to position those tests in your practice. Now, this is I'd like to emphasize that there's always a question, should I use in my patient pH impedance off treatment, or should I use, pH impedance on treatment, or should I use wireless pH capsule or catheter-based pH off treatment? And the answer to that is, if the patient has history of documented gastroesophageal reflux disease, then you should keep them on the PPI and perform a pH impedance. If the patient has no history of documented GERD, no evidence on upper endoscopy of erosive esophagitis, and there is no evidence of abnormal pH test, then you should take them off PPI and then perform the catheter-based pH test. So I think I'm a little bit 3 minutes behind, but I would like to conclude here, and I would like to thank you for giving me the opportunity to kind of update you in how we use today esophageal manometry and pH impedance or pH assessment in diagnosing gastroesophageal reflux disease.
Thank you, Professor Ronifas, for your update lecture about modality of diagnosis in GERD. So we invite the second speaker, please, Dr. Amanda.
Thank you so much, and good morning, Dr. Darmika, and probably good evening to Professor Ronifas. Thank you for a very nice. I'm gonna share my screen for. Okay, can somebody allow to share my screen, please? So, Professor Ronifas has talked about many kinds of functional tests which can be used in a patient with gastroduodenal disorder. how to implement it in our daily practice, I will present two cases which I found in the practice to can you see the slide?
That's okay.
I do.
Okay. So we can have a better understanding about these procedures, because frankly speaking, this kind of procedures is already new in Indonesia. So let me start with the first one. This is a 57-year-old female. She came with a complaint of fullness since 5 months. The feeling of fullness in her stomach worsened since about 5 months ago. When she forced herself to eat, she experienced nausea and sometimes accompanied by vomiting. And she had excessive belching. No particular type of food induced her symptoms. Food intake was decreased significantly, and she had lost like 7 kilograms of body weight during these 5 months. Lately, she also felt pain and burning sensation in her epigastric area after eating. She had been treated with PPI once a day for a few months, but had no relief of her symptoms. When she came to us, she still taking omeprazole 20 milligrams, and she consumed it 30 minutes before breakfast. Bowel movement was as usual, no straining, and every 1 to 2 days. She had a type 2 diabetes, well controlled since 8 years ago, routinely taking metformin and glycoside, and hypertension since about 8 years ago, routinely taking amlodipine and valsartan. She had history of ischemic stroke and coronary artery disease about 3 years ago, and routinely taking clopidogrel, and no history of significant disease, no history of alcohol consumption or smoking. She used to work as a banker but has now retired, married with 3 children. From the general appearance, she had a slightly overweight, mildly ill with ear control hypertension, and mild pain in the epigastric area. This is her laboratory investigation, all still within normal, I think. Her random blood glucose is normal, and then ECG is, we can assume it's normal. So this is a common patient that we often see in our clinic. What is the diagnosis? Do we need endoscopy in this patient?
Dr. Amanda.
Right? Yes, Dr. Darmika.
Dr. Amanda.
Yeah.
This patient with diabetes mellitus, as he has another complication or look like retinopathy, neuropathy, and nephropathy in the case.
Nephropathy, no. Retinopathy, no. She complained of a bit tingling in on her fingers. Yeah.
Prof. Roni,
Yeah.
your suggestion?
So, I mean, this is, whenever I see a patient like this that have a combination of diabetes and this type of symptoms in the context of long-term diabetes, some evidence of peripheral neuropathy. The hemoglobin A1C is not that bad, but a random blood glucose was high. I'm always concerned, obviously, that the patient might have delayed gastric emptying. And we do know that delayed gastric emptying can exacerbate gastroesophageal reflux. And it is one of the patient can develop refractory GERD.
So,
Okay.
Dr. Amanda, what next?
So the question is, should we do endoscopy? I always start these cases with endoscopy.
Okay.
Yeah.
So in this patient, yes, this is just an algorithm that account patient, gastrointestinal disorder, and then there's alarm features. In this patient, we found weight loss, significant weight loss, and then we can go directly to the upper GI endoscopy, and this is the findings of the upper GI endoscopy. We found a panoramic esophageal mucosal layer with a bit large mucosal break, and then also a bolus of food in the stomach. So the conclusion is the esophagitis and a delayed gastric emptying, just like Professor Fuss said. So do we need more diagnostic tests in this patient?
Prof. Roni?
Can we hear what
Yeah.
the audience want to say?
So the question is, what would you do next? And usually in our place, while we do have evidence of delayed gastric emptying by the presence of food, we usually order gastric emptying to document and see the extent of the delayed gastric emptying. So that would be probably my next step, to perform and cement the diagnosis of delayed gastric emptying.
What your next examination, Dr. Amanda?
In this case, I did not do any gastric emptying test because at that moment I think, oh, this is already conclude that it's the delayed gastric emptying. But like Professor Fuss said, probably we should observe the extent of the delay, because we can use it in the therapy, probably, Professor, to evaluate the response of our children. Okay, so this is the confirmed GERD based on the criteria that it is LA grade C or D, and that we find in the upper GI endoscopy. And then this is the cascade for the diagnosis of GERD. I will be using the guideline of WHO because some area in Indonesia is still limited in resources, so we have to apply the guideline based on the available resources. So whether limited resources, medium resources, or high resources. In this patient, we already performed the upper GI endoscopy, and so probably we can try to give the patient PPI therapy. And then this is the gastroparesis, just the definition that symptom characterized by nausea, vomiting, early satiety, and other symptoms in the presence of delayed gastric emptying, which is without any evidence of obstruction based on the upper GI endoscopy. In this patient, the etiology most probably is diabetes mellitus, and then it is said that still, yes, gastric scintigraphy is considered the gold standard investigation for diagnosing motility, and the other test is gastric emptying test and motility capsule. In Indonesia, we only have gastric scintigraphy at the moment. So this is just an example, not in this patient. So more than 10% at 4 hours is diagnostic of gastroparesis, right, Professor Fuss? Okay. So what is the treatment after with these findings? What is our plan next?
Yeah, I would like to comment. So first of all, in our place, we perform the gastric emptying study only the 4 hours. We don't use anymore the 2 hours study. That's been the problem with that is because it's the 2 hour study is associated with highly false positive. So if you get a positive test after 2 hours, it may not be positive after 4 hours. And so a lot of patients got the diagnosis of gastroparesis that didn't have it. So we do use the 4 hours today. This is a, this patient, in my mind, the patient has kind of severe gastroparesis. I don't see a lot of patients with gastroparesis that throw up, that have vomiting. When they come and present with vomiting, usually they have a form of the disease. Also, when they get to the point that they start to lose weight. That also suggestive that this is a severe form. In fact, there was some of the recent studies that were done with new compounds for gastroparesis that focus specifically on patients with vomiting. They had hard time to fulfill the number of recruited patients because they're not that common. So here we have a patient that is appears to me really sick. I'm not sure how much he did in order to deal with gastroparesis, but from a treatment point of view, we always start with the following. In the case of diabetes, we always start with good diabetic control. Now, it's true that the hemoglobin was good, but a random check was 174, that's high. And there's a close correlation between gastric emptying and the level of sugar in the patient's blood. The higher the sugar in the blood, the slower is the stomach. So it's really important to keep a very tight control of the sugar. Also, diet. Nutrition is a big deal in these patients. Low fiber and low fat is the basic concept. And then you add to it that patients should count more on soft and liquid diet instead of more solid meals. In a patient like this, you might need maybe a prokinetic that has some antiemetic effect. That could be helpful because she's got vomiting. In that case, I would consider something like Reglin or metoclopramide. I don't know if you have it in Indonesia, but you can use one of these prokinetics, or if you can use a combination of a prokinetic and antiemetic medication. Patient has to be re-instructed about quality, about lifestyle, and the weight should be followed very closely. One drug that I would consider in a patient like this is mirtazapine. Mirtazapine is a central drug, and it has an antiemetic effect, and also can help with improve weight in a patient that.
Professor.
Sorry, there's a lot of noise.
Fast. There's correlation. It's correlation. Yeah.
Hello.
It's a correlation about
Hello.
Hello?
Yes, we hear you now.
You hear me?
No, I cannot.
Gastric emptying and clinical symptoms. Sometimes there's improvement of gastric emptying test, but the clinical still severe. Amanda?
Sorry, but I cannot hear your I cannot hear your voice, Dr. Dharmika.
Emptying test and improvement of the clinical symptom.
Is it just me?
Okay, you start. Dr. Amanda.
Yeah. Yes. Okay, now I can hear you, sir.
Okay, you start your presentation.
Yes, now I can hear you. Okay.
Okay.
This is from guideline of how to treat diabetic gastroparesis, and this is from the first lecture 2 weeks ago. Yes, we try to educate the patient to do some modification to improve the compliance and optimize the drug. And always the first time is the glycemic control through lifestyle modification or pharmacotherapy. We evaluate any kind of drug therapy that the patient had, then assessment of the. In this patient, the oral anti-diabetic was used, and then patient was put on twice daily Variceal and gave her blood test. 2 months later, she still experienced fullness and heartburn in lower intensity. No vomiting and body weight was stable. So what is our next step? Are we satisfied with this result, or is there any possibility that we should
Play the solves play and on the night of stage wise were present. I mean, it's all on the and patient that the patient does have. There's a heartburn. To be good.
Terima kasih. Oh, gitu. Oke. Asal jangan
Hello. Dr. Darmika.
So let's start your presentation.
I cannot. There's many noise. I cannot hear.
Kepada para peserta, karena ada gangguan sinyal dari Zoom-nya sepertinya, kita boleh keluar dulu sebentar dari Zoom, nanti dicoba refresh, masuk kembali ke dalam Zoom-nya. Ya, dimohon kesediaannya untuk semua peserta serta speaker, to all speakers, because there's an internet connection trouble. So we may go out from the Zoom and then we go back to the Zoom again, and we will refresh the Zoom. Thank you very much.